presentation, Prevalence of Glaucoma and East India Study, to be presented by Chandrima Paul. Ma'am, your membership number, please.
C5632.
Right.
So, honorable judges and dear colleagues, Prevalence of Glaucoma and East Indian Study, I acknowledge my co-authors. I have no financial interest in the study. The aims of the study was to assess and compare the prevalence and types of glaucoma in the rural Hooghly district and urban Kolkata metropolitan city East Indian population. It's a population-based cross-sectional study divided into two divisions, the epidemiological fieldwork and hospital-based clinical examination and diagnostic procedures. The rural study area consisted of 13 gram panchayats from the district of Hooghly in West Bengal, which are about 20 kilometers surrounding the rural base hospital located at Dhobapara in the circle there. And the urban study area was the Kolkata metropolitan city. Kolkata is divided into 15 bureaus and 141 wards. The one division was randomly selected from each of these 15 bureaus, and 8 subdivisions were taken from the randomly selected 15 divisions. And the tertiary eye hospital was in central Kolkata on the AJC Bose Road. So, assuming a 3% prevalence of glaucoma based on the other prevalence studies, a relative precision of 25%, 85% and 90% compliance, and a design effect of 2, we required a sample size of 4,300 for the rural and 4,500 for the urban. Therefore, 10,994 subjects from the rural and 11,290 from the urban were enumerated. Social workers and volunteers conducted a door-to-door survey and distributed household questionnaires from which they collected demographic information. The eligible subjects were given a unique 10-digit identification number and were motivated for the clinical examination on a convenient date to the base hospital. Apart from the routine ophthalmological examination, frequency doubling perimetry analyzed by glaucoma experts, corneal pachymetry and intraocular pressure were measured, gonioscopy was done, and fundus and the optic disc was evaluated at the slit lamp using a +90D. Inclusion criteria were people aged 40 years and above, residents for a minimum period of 6 months and willing to participate. These were the exclusion criteria. So, International Society of Geographical and Epidemiological Ophthalmology recommendations were followed with some study-specific modification. Those modifications were presence of a cluster of 3 contiguous points at the 5% level or less on the pattern deviation plot of the N30 threshold test done on the FDP. And glaucoma was diagnosed on the basis of structural and functional evidence or evidence of structural damage when reliable field testing was not possible, or when the optic disc was not visible, IOP at the 99.5th percentile, or evidence of filtering surgery. So data analysis was done using SPSS version 23 and Microsoft Excel 2016. Threshold for statistical significance was set at p less than 5.5%. Student t-test and chi-square tests were done for the variables, and the multiple groups were compared using analysis of variance. The risk factors for glaucoma investigated using univariate and multivariate regression analyses, and odd ratios with 95% confidence intervals were calculated in the regression analyses. So the mean IOP in the rural division was 16.5 with 25 millimeters of mercury and 30 millimeters of mercury at the 97.5 and 99.5 at percentile. In the urban division, it was 17.2 with 27 and 31. The VCDR in the rural division was 0.4, and that in the urban division was 0.5. There was a positive correlation between the intraocular pressure and the VCDR in both the groups. The glaucoma prevalence was found to be 2.6% in the rural population as compared to 3.1% in the urban population. So the glaucoma prevalence also varied with age. It increased with age in both the groups. And the types of glaucoma, as you see out there, if you look at the pie chart, it's almost 50-50 in primary open-angle glaucoma and angle closure glaucoma, with a small division of secondary glaucoma. So there was a positive correlation between age and intraocular pressure and VCDR. However, the correlation of age with VCDR was more significant than that with intraocular pressure. The distribution of intraocular pressure, vertical cup disc ratio, was obtained from the right eye of subjects with suprathreshold normal visual fields in both populations. Increasing IOP and older age were associated with the disease, and the prevalence was significantly higher in the rural population and the urban population than in the rural. So, reviewing the literature, I found that prevalence of glaucoma did not differ by gender. This was also found in the other studies, and prevalence of Primary open-angle glaucoma was higher in the urban population, also found in the previously done epidemiological studies. Prevalence of glaucoma actually increased with age, and the VCDR was comparable to the Chennai glaucoma study that we got, and we also used the modified ISGO, which was used in the other studies. FDT positivity was significantly higher in the urban group. This was also evident in the Chennai glaucoma study, and 92.4% in the rural population and 91.5% in the urban were actually unaware that they had the disease, which is also comparable with the Chennai glaucoma study. And the ratio of primary open-angle glaucoma to angle closure glaucoma was 1.26:1 as compared to 1.1:1 in the urban group. So the conclusions were the average IOP, CCT, VCDR and FDT positivity in both eyes was similar in both the rural and urban groups. IOP showed a positive correlation with age and VCDR in both the groups. POAG is more common in both the rural and urban groups. PSCD is much more common in this region than previously thought. The study strongly recommends that gonioscopy should be made an integral part of glaucoma screening programs, and the findings of this study will help in developing public health strategies for early detection of glaucoma. Thank you.
Thank you, ma'am. I wanted to know two things from you. For having the rural screening, did you take a portable the slit lamp with you?
No, sir. We actually had a base hospital in the rural area, which was 20 kilometers surrounding that area, which we did the door-to-door survey. So the people were transported in the vehicle from their houses to the base hospital in the rural area, and that is where it was conducted, the tests.
Did you perform gonioscopy with single mirror or 3-mirror gonioscope?
No, we performed gonioscopy with 4 mirrors, sir.
4 mirror.
Yes.
3. Why did you not take account of angle closure glaucoma also? Chronic angle closure glaucoma.
Yes,
that has also become a very important blinding disease now.
Yes,
now we blame it more than POAG for.
Yes, sir. That is what we found, that the angle closure disease in the previous West Bengal study was 1:10, whereas in our study it's almost 50-50 angle closure.
Right. Thank you.
So the thesis was on a much smaller subject, but yeah, but this is on a much bigger platform.
No financial disclosure, no professional disclosure. Thank you, ma'am.